Hello, welcome to X-Ray Matters, the podcast where we explore why X-ray really matters in healthcare today. I'm Ryan, your host, and in this episode we're heading to South Africa. Our guest is Dr. Ashesh Ranchod, a radiologist with over 20 years experience in private practice, and he's the co-owner of one of the country's leading radiology groups. We'll look at the unique healthcare landscape in South Africa, the role private radiology plays in supporting patient care, and how mobile X-ray units with on-device AI are delivering fast, life-saving support right at the point of care. Leading the conversation is Professor Matthias Goyen, Chief Medical Officer at GE Healthcare. Let's get into it.
Ashesh, it's a pleasure to have you with us. Welcome to the show.
It's an absolute honor. Thank you, Matthias.
Let's begin with a question we ask all our guests. Why does X-ray matter to you?
I think X-ray matters to me because it still remains one of the most convenient, cheapest, quickest, and easiest imaging modality utilized to diagnose pathology. As an example, if a patient presents with abdominal pain and there may be bowel obstruction or kidney stones, we know that the CT may be needed to make a diagnosis, a high-tech imaging modality, but the door to the CT is usually the X-rays. In some instances, X-rays is the only modality we can utilize to help the patient and the clinician. As an example, neonatal X-rays and premature infants, none of our other modalities will help us identify lines, tubes, and lung pathology, especially in a premature infant at 27 weeks gestation. We need the basic stock standard X-ray to help us.
Ashesh, you've had a remarkable career spanning over more than 2 decades in private radiology. What inspired you to pursue radiology in the first place? There are so many specialties, and how has your career evolved over the years?
You're going to laugh when I tell you that I'm like an accidental radiologist. As far back as I can remember, I always wanted to become a medical doctor. So if you ask me before primary school, I wanted to become a doctor. And by 8 years of age, I knew the definition of rigor mortis. Forensic pathology was what I was interested in. However, as I pursued my medical career, the intersection of violent crime and forensic pathology was a bit disheartening. And I then looked into nuclear medicine and radioisotope imaging. But I was unsuccessful in obtaining a traineeship in that, and I pivoted to radiology. I must be honest, I don't regret that decision one bit. Every single day, my specialty excites me, and I enjoy the diagnosis and management of imaging patients and diagnosing pathology. So I don't regret becoming a radiologist one bit.
And your patients can be glad that you finally became a radiologist. That's really great.
I'm sure they can vouch for that.
So you've built one of South Africa's largest private radiology groups. Can you talk a little bit about the milestones you achieved, or what were some turning points?
So I'd correct you there and say maybe not one of the largest, a medium-sized practice. But I mean, just to be contextual, we started off with 3 radiologists in the background approximately 24 years back. And we were 2 radiologists working in the practice and having a support staff of 7. After 20 years, we are now 4 different sites, 13 radiologists, and a support staff of 180 individuals. We have 3 hospital-based practices. We see anything from 9 to 14,000 patients a month, and that has evolved over the period of 21 years. And that has been the success of the practice in terms of where we started and where we're at currently. We provide important services in private healthcare in South Africa, and we've been pioneers and innovators in terms of adopting new technology that has often come about.
You live and work in South Africa, and we all know that South Africa has a unique healthcare landscape with a mix of public and private systems. Can you give us an overview of how the healthcare system works?
Sure. So we have a mixture of public healthcare, which supports bulk of the population, and we have private healthcare, which is supported by individuals that either have private funding or have third-party funding, as in medical insurers. So they access the private institutions that provide services, and you can get world-class care in these institutions. We have the public service that is buckling under the pressure of having a huge patient base, having under-resourced facilities, and also having local and foreign patients to support. South Africa as a country is unfortunately imaging or treating a lot of the local residents in the vicinity. So it's a lot of strain under the public healthcare system, but we have a private healthcare system that is thriving.
So you mentioned the private radiology groups. Can you elaborate a little bit about the role of the private radiology groups in supporting the broader healthcare system in South Africa?
So the private radiology groups are based in private clinics or hospitals, as we call them. And the supporting structure is that we feel that the government and the country is gravitating towards a national healthcare system. And they are now promoting universal and equal healthcare to all. It's a goal that we all aspire to and would agree with. And we'd love that private radiology will be part of that public solution in providing ancillary and support services in imaging public patients in some sort of mechanism that will yet to be agreed upon.
What would you say, what are the biggest challenges in managing a private radiology group today in South Africa?
I think the challenges seem to be more and more pronounced as we go forward. We have local challenges and we have macroeconomic challenges. I think the macroeconomics, based on the fact that South Africa is so far down south and all our equipment has come from Northern Hemisphere countries, so we have to then be mindful of the rand dollar, rand pound, rand euro, yen rates. That makes equipment purchasing extremely expensive. And so feasibility studies are quite difficult. Parts availability is something that affects us as private institutions. So parts availability far south that needs to be, or parts need to be obtained from Northern Hemisphere countries can delay us and also give us downtime in terms of our equipment. And staffing. Staffing is a huge problem going forward. We're training lots of technologists, radiographers, sonographers. But as you know, the world has become a small place. And a lot of our staff are emigrating and supporting lots of other countries. So the turnaround is something that's affecting us significantly nowadays, both in public and private institutions.
Let's now dive into the topic for today, that is mobile X-ray and AI. We know that your group has implemented mobile X-ray units equipped with AI. And maybe the first question is, when choosing imaging technology, what are the main drivers behind your decision?
So we always look at the needs of the practice, and the practice growth has determined what imaging modalities need to be purchased. And if we take mobile X-rays as an example, so we start off with one mobile unit, and as the hospital expanded with multiple sites requiring mobile X-rays, the one branch has approximately 4 mobile units. So you started off at one, and then the imaging needs grew and grew and grew, and you now have 4 different units that are providing the services because the size and breadth of the hospital determines and demands that. So that has happened in all other modalities as well. You have one bucky room and then you have to expand to a second and third bucky room. Coming closer to the AI technology, we encompass the AI and observe the AI technology approximately 4.5 years back. And this was an important consideration. We haven't really adopted massive AI software in the practice. One, cost prohibitive. I alluded to the forex rates that affects us in terms of equipment purchases. The same would apply to software purchases, and that makes AI solutions a bit cost prohibitive. The benefit of having AI in overseas countries, and as they use AI and correct it and amend it and improve it, we're hoping that we will reap the benefits of that process a little later down south. So in that manner, we've adopted the first AI solution we adopted was the critical care suite.
So Ashesh, you really have to balance, on the one hand, the clinical needs. On the other hand, you mentioned it, the cost effectiveness and also innovation when investing into new equipment. How do you do it before we dive into the critical care suite?
So one, we have to recognize that the imaging service is needed. And as an example, our practice does not have PET-CT. But we've built a huge oncological imaging base over the last few years. And now we've realized that we need to offer this imaging service to that patient profile. So a PET-CT is needed, and that is the project on the table. So we'll go through the feasibility, we'll go through the site, we'll go through our nuclear medicine partners that we need to discuss and negotiate. And that's how we look at each mini project as we go along and introduce the modality to our practice.
So, Ashesh, why did you decide, and you mentioned 4.5 years ago, to implement AI solutions in mobile X-ray? What was the rationale for you to do that?
So when we assessed the availability of mobile solutions and AI software at the time, we were quite intrigued by the novel idea of AI at the point of care. And this is the critical care suite that offers you instant, within a second, AI analysis of endotracheal tube placement, the identification or the absence of a pneumothorax, atypical positioning, atypical exposures, and the benefit of being able to make that decision autonomously at the bedside prior to the radiologist intervening attracted us. Yes, the radiologist overrides everything at the end of the day, but we are not working 24 hours a day. There are days when you're driving to work. There are days when it's public holidays. There are days when you have polytrauma scans that take precedence over the reporting of x-rays. And if AI and critical care suite can triage those patients, will question your list to say, dear radiologist, there's an urgent chest x-ray that needs to be reported. If you don't report this x-ray, there is a chance that the patient will resuscitate and demise. And I think we have to then encompass that. So it was a novel and intriguing software purchase. And I must be honest, we cannot see ourselves going forward without the critical care suite in all mobile solutions.
So you mentioned the pneumothorax, a collapsed lung, which is a condition that ICU doctors really fear because if not detected on time, it can be potentially deadly. So can you walk us really through how the AI solution works in your practice, what it does and how it really supports clinicians? Let's say it's 3 o'clock in the morning, there is the need to do a chest x-ray on the ICU. Just for our audience, how does it work?
So sure, the normal and routine requests will come through and everything is now IT dependent. So the request is digitally processed in the department and the tech on site that's sleeping on site will get the request for an urgent mobile chest x-ray. And oftentimes you find the patient is either unwell or it's been an admission at 2 o'clock in the morning, or the patient has come out of theater, or the patient has had a CVP instituted, or a patient has been intubated due to various reasons. And oftentimes when the patient first presents to an intensive care unit, the base x-ray is always requested, right? You want to see before you start managing the patient, where does everything lie? And so the request goes through and it gets processed and the tech goes on site and performs an x-ray. And depending on the reason for that x-ray, the sister treating the patient or the clinician that is putting the CBP or the clinician that has intubated the patient usually spends a few seconds around waiting for that x-ray. In the past, they would have waited much longer. We would have had dark rooms. And yes, these x-rays are not getting reported. The situation that has changed nowadays is that the mobile x-ray gets done. The AI is at the point of care. If it was an endotracheal tube assessment, the image is there within a second or two. If it's a pneumothorax that is present in the patient, it's red flagged. The percentage is there as to what the threshold and what the AI solution is thinking in terms of the pneumothorax. And these patients may be stable. They need not be distressed in terms of the pneumothorax. The pneumothorax is going to complicate at an unexpected and inopportune time to a clinician that doesn't know why the patient is resuscitated. So once the pneumothorax is identified, if the clinician is around, well and good. If he's not around, the sister gets informed, and then she calls the doctor. The radiologist on call gets informed, and the image is reported. OB 3 o'clock in the morning, it's reported, and then management is afforded to the patient.
And before the app detects or flags critical cases, it even tells the radiographer doing the scan if the scan was done properly, in a proper manner. Is that right? Like a quality control system?
Yes, that is correct. The critical care suite also does a quality assessment in terms of exposure. It also red flags an atypical position for whatever reason, and in addition to the endotracheal tube and the pneumothorax assessment.
So when the tech does the exam and it's done in a proper way, it shows a probability of that patient having a pneumothorax, for example. What happens then?
So that we've trained our students and our techs, qualified techs, to be able to interpret the AI in terms of the fact that we're not requesting them to be push button technologists. Just go and do the X-ray, press the buttons, come back, process it, and leave the X-ray on the PACS in terms of a soft solution. When they do the AI processing, they usually do it at the point of care. If the sisters are there, they tend to highlight it to the sister to say, there is the position of the ET tube. There is no pneumothorax here. It's been 0% chance of a pneumothorax. And they're happy with the position. It's a self-decision in terms of their quality control. And once they've conveyed that information instantly, live, at the site, at the bedside, they then proceed back to the department and process the x-rays. So we're not just asking them to press a button to process the critical care suite. We're asking them to look at the results of that critical care suite, convey the results to the sister or the treating doctor, and if they red flag, convey the results to the radiologist on call as well. So it's not that you come the next day and the critical care suite has identified a pneumothorax and no one's did anything about it. More often than not, the pneumothorax has been identified without the knowledge of the radiologist. Intercostal drain has been inserted. The follow-up x-ray has been done. In the morning when the x-rays are reported, you're reporting 2 x-rays, one with a pneumothorax, one with the intercostal drain.
I just was about to ask, what is the role of the radiologist then? Because very often, as you said, the ICU doctor sees the image first with the heat map and the probability of this patient having a pneumothorax, right?
You can argue that is the AI solution making us superfluous and it's been autonomous. It's making decisions without our consent. However, if that diagnosis is made, who benefits at that time? The patient benefits at that time. And overall, is that not our final aim, to be able to treat patients as most cost effective, as most convenient, and not to get surprises? That's what we don't want, is surprises. So yes, the next morning you might find that everything's happened without you being excited about it or knowing about it. But you know what? You look at the reports, you look at the x-rays, you report the x-rays. Here and there you make decisions to say, yes, it red flagged the pneumothorax. You were not happy that it red flagged the pneumothorax. Maybe a CT scan is indicated, and then you would request a CT scan. So, and you can spend your time being more efficient in looking at other more important studies that may deserve your attention.
And I guess you agree with me, the patient is the winner.
100%. The patient wins at the end of the day, and that's our final aim. No matter who's did all the hard work in the background, it's not about recognition. We need AI. As we say, AI says artificial intelligence. I like to call it augmentation intelligence. Whether it's working after hours or whether it's working with or without the radiologist, we need to enhance and utilize AI to augment the radiologist. He becomes more efficient. He becomes more accurate. And we know in certain instances the AI can be better than the radiologist, but it's a combined tool. It's one of our armamentariums to be able to afford cost-effective, accurate care to the patient.
And it's not the question if the AI outperforms the radiologist or if the radiologist is still better. It's just about prioritizing critical cases, right?
Yes, the AI helps us triage. If we have multiple x-rays coming through and you don't know where to start sometimes, you don't know whether to start on the first x-ray that's been done, whether to start on the last x-ray that's been done. And, if you have 50 portable x-rays, we're doing something like 14,000 mobile x-rays a year. If you have a triaging tool that tells you there's 20 x-rays that have been done, one is absolutely urgent, and you would then report that one first, and you would then triage your own time as to how you tackle the list of reporting. So AI is there to save lives. It's there to enhance and augment your list, and it's helping you triage.
So what kind of impact have you seen since implementing AI more than 4 years ago? You have a great deal of experience with it. Could you just share some of very impressive examples? I know you have them from your own practice.
So I must be honest, it's created chaos. What do I mean by that? It's created an organized chaos. We have multiple mobile units in the department, and when the technologist is called to perform an x-ray at a remote facility, either in the ER department or one of the ICUs, as I said, in our biggest site, there are 9 different zones for mobile x-rays to be performed. So the 1 or 2 zones are quite far from the department, and the tech then takes the unit and proceeds to the department. And what happens there, if he has come on site without the solution with the critical care suite, the sister or the treating doctor will send them back. Please go back. Why did you come with this mobile unit? Why did you come with the fact that we're not going to be able to process the critical care suite? Please come back with the unit that has the critical care suite. So we find that the radiographers are now becoming slightly inefficient because they are not, they've been sent back to bring forward the suite, the AI suite, to assess those x-rays. What happens in those instances is that we have 3 other units in the site. There's 4 mobile units, and only now 1 unit is getting used because that's the unit that has the critical care suite. We've had an interesting concept in the ER department. We have an overhead bucky room in the ER department, and the doctors, the treating trauma surgeons, as well as the ER sisters, are requesting the mobile X-ray to be done rather than the bucky room X-ray to be done, because the bucky room doesn't have the AI critical care suite. They would prefer the mobile X-ray, get that interpretation, and they feel they're more accurate, they feel they're more efficient, and instead of having the tech come there, do the X-rays, process it, come back, to repeat the X-rays, they feel the instant assessment on the AI is what makes what they prefer. So the bucky room is now becoming redundant in terms of the fact that the mobile has the AI critical care suite. So yes, a bit of organized chaos in the department.
It's really great to hear, Ashesh, that the clinicians really demand to have the X-ray done with a critical care suite. And this leads me to the question of acceptance or adoption of this technique. When you introduced it 4 years ago, were some of the clinicians kind of skeptical? What is this AI? Because we were so used to doing it old school, to look at the image, or was there a learning curve? If you can talk a little bit about that from a radiologist perspective and the referring physicians, the ICU doctor's perspective.
So there was a learning curve, and when we first introduced the AI software, we needed to learn the intricacies of the software ourselves first before we rolled it out. So we had a two-step rollout in terms of the software. The first software was to teach the technologist. The first training is that they doing the X-rays, they need to now be taught how to process the AI, how to interpret the AI, and what the decision-making tree was when they were processing the AI. While they were doing that, I, as a radiologist, now rolling out this critical care suite, was assessing the images. The first problem we encountered was that our monitors were black and white, and the software was color. So we then had to engage GE to try and get a solution for us to interpret the critical care suite on a black and white monitor. Subsequently, we have purchased color monitors, and now we're reversing back to color. So we had to learn nuances in terms of what the software does, what the implications are, and how do we process it from the tech perspective, from the radiologist perspective. Once we were okay with that situation, we then rolled it out to our clinicians, to the point where now the clinicians lurk behind the tech. As the tech is there positioning the patient, exposing the X-ray, the clinicians are pressing the buttons on the mobile unit processing the AI. So they don't even want to wait for the technologist to process the AI, even though it takes 2 seconds. As he exposes, they immediately pressing the AI button, waiting for that image to come up. So we find that this is what's happening in the departments.
It seems to me, listening to you when you talk about AI and X-ray, it's limitless opportunities. But let's talk about the limits of AI. I'm sure you also have experience with that. What can you share with regard to limits of AI in mobile X-ray?
So I think we've had interesting X-rays when you've had atypical positioning, and sometimes, let's be honest, you're forced to do an atypical position. Because when you're doing mobile X-rays, we are not really wanting to mobilize the patient in a particular position. So you have to expect that mobile X-rays will have atypical positioning. This is the norm. An ICU patient, a restless patient, a patient undergoing a resus, a fighting baby, a newborn baby is going to have an atypical position. And then the AI can get a little confused, for want of a better word, in an atypical position. Yet we found the software is very robust. It absolutely identifies the ET tube in all positions. It doesn't identify the pneumothorax in certain positions, and we can understand and appreciate that concept, that it's not 100% perfect. And that's where the role of the radiologist also comes through. If the AI has red flagged the pneumothorax, the radiologist should look at that threshold and also make a personal call, whether he agrees, whether he disagrees, whether it's equivocal. Maybe the AI is correct, maybe the AI is incorrect. And then also decide the further management in terms of that. Do we do a CAT scan? Do we recommend a CAT scan on the suggestion that there is an occult pneumothorax that needs to be treated?
So looking ahead, Ashesh, what innovations in X-ray or AI excite you the most personally?
I think the fact that we do a majority of the imaging is X-rays, and AI that's going towards fracture detection, going towards osteoporosis detection in routine X-rays. That concept of AI that's picking up unidentified, unexpected pathology. That's what's exciting me at the moment. So we're doing a chest x-ray for a completely unrelated reason. Let's say the patient is preoperative, not presenting for any chest pathology, presenting for some sort of hip replacement. And we do a preoperative x-ray, which is indicated by the anesthetist in terms of assessment for anesthetic risk. And then the AI will identify something completely isolated, unexpected. And yes, it will trigger a cascade of events. You may argue, are we overdiagnosing? It's not about overdiagnosing. If the patient has a lung cancer and no one knows about it, and we've did this x-ray for the knee or hip replacement, I think that's extremely important, because the earlier we can diagnose something, the better we can manage the patient. We're going to save lives eventually. There's an element of overdiagnosis, but it's going to be balanced overall.
I couldn't agree more. This absolutely resonates with me, this concept. Finally, what advice would you give to younger radiologists, to your younger self probably, looking to develop their career?
I think there's a trend amongst younger radiologists looking for some sort of work-life balance and flexibility, and seemingly teleradiology seems to be a very attractive option to them. My advice to younger radiologists is that please do not lose the art of speech and communication, and also do not lose the art of utilizing your hands. What do I mean by that? Well, we are social beings. Human beings are social beings. We've always communicated and talked to solve problems. And I think if you are off-site and you're at home, you may not talk to clinicians enough. You may not talk to patients enough. Yes, we don't have the time to talk to every single patient for every single imaging study. We'd love to, but efficiencies demand otherwise. I think the patient that deserves a discussion, the patient that's anxious, you need to be available to be able to talk to the patient. The clinician that pops in to discuss a complicated case, to discuss your findings, and then to discuss further imaging studies, I think you need to be on site to be able to do that. Yes, you can do it from home, but coming to the skills of your hands again, by sitting and doing teleradiology, we're losing the art of interventional radiology. And there's a huge request for interventional radiology to be able to perform simple FNA procedures, core biopsy procedures, drainages, nephrostomies. And I'm not talking of the complex neurointervention endovascular cases or complex vascular intervention cases, just simple basic stuff of putting in drains, pigtails, FNAs, which make diagnosis easier, which helps clinicians. And these procedures are not being taught and trained to younger radiologists who feel that teleradiology is the solution to everything. I think that it should be a hybrid environment. There should be a component of teleradiology in the practice. If there's busy times in the department, maybe someone at home can help you report certain x-rays. But I think radiologists should not lose the art of talking, discussing, communicating, and negotiating procedures, etc., with clinicians. And also, don't lose the art of using your hands.
Ashesh, thank you so much for sharing your insights with us today. It's been a pleasure having you on X-Ray Matters.
Thank you.
Okay, that's it for today's episode of X-Ray Matters. A big thank you to Dr. Ashesh Ranchod for sharing his experience, and of course to Professor Matthias Goin for guiding this discussion. We heard how South Africa's healthcare system depends on strong support from private radiology, and how mobile X-ray enhanced with on-device AI is providing critical, life-saving decisions where they're needed most. If you enjoyed today's episode, be sure to share it with your colleagues, follow us on Spotify, Apple Podcasts, or wherever you may listen, to hear more from around the world on why X-ray matters.